Good morning. I appreciate you taking the time to listen to my presentation. My name is Tim Dawson. I'm a fifth-year surgery resident from the University of Louisville. I'll be presenting a paper titled Comparing Patterns of Care and Outcomes After Operative Management of Complications After Bariatric Surgery at MBSAQIP accredited bariatric centers and non-bariatric facilities. I'd like to thank Drs. Budiani, Benz, Miller, Bozeman, Nash, Katie, and Motamini for their help in this work. Most of us are from the Department of Surgery at the University of Louisville. Dr. Motamini was a fellow at the University of Louisville, but he's now at Wake Med, Raleigh, Department of Surgery in Raleigh, North Carolina. None of the authors of this work have anything to disclose related to this presentation. For those of us who have done bariatric surgery, we know that it is a complex foregut procedure that comes with inherent morbidity. About 1 to 4% of bariatric surgery patients will require surgical, radiologic, or endoscopic interventions for a complication within the first 30 days of surgery. About 8% of bariatric surgery patients require readmission within 90 days of surgery. And up to a quarter of bariatric patients will require an admission to the hospital for a complication of their bariatric surgery at some point after their surgery. The most common complications requiring intervention can be summed up into the categories of bleeding, leak, or obstruction. In this study, we used Metabolic and Bariatric Surgery Quality Improvement Program, Centers of Excellence, in our assessment. Over 90% of bariatric surgeries are performed at these MBSAQIP Centers of Excellence. However, 20% of readmissions within the first 90 days of bariatric surgery are to a hospital other than the hospital at which the index surgery was performed. And there's currently a lack of evidence to evaluate whether or not requiring surgical intervention for a bariatric complication at a bariatric center of excellence versus a non-bariatric center of excellence has an effect on patient outcomes. So the objective of our study was to evaluate whether undergoing surgery for a bariatric complication at a center of excellence versus a non-center of excellence affects patterns of care, cost of care, or perioperative outcomes. To do this, we used administrative claims data from the Kentucky Cabinet for Health and Family Services, Offices of Health Policy. We chose to include patients who underwent an operative intervention for a complication of bariatric surgery between October 1st, 2015 and December 31st, 2018. To do this, we used patients with ICD-10 diagnosis codes consistent with complication of bariatric surgery, as well as an ICD-10 procedure code consistent with requiring surgical procedure for this complication. Patients were stratified as to whether or not they underwent surgery for their complication at an accredited bariatric center of excellence versus a hospital that was not a bariatric center of excellence. The variables we compared were patients' age, gender, ethnicity, comorbidities, insurance status, whether they had a laparoscopic versus an open surgery, length of stay, inpatient mortality, discharge destination, and total hospital charges. For the results of our study, this first table shows demographic comparisons in patients who went to BCEs versus non-BCEs. And again, that's bariatric centers of excellence versus non-bariatric centers of excellence. You can see in this table, the second column are patients who went to bariatric centers of excellence, and the third column are patients who went to non-BCEs. There was no significant difference in the patients' ages on the patients that went to BCE versus non-BCEs or a patient's gender. However, we did find that there was a significant difference in ethnicity, in which African American patients were more likely to go to a non-BCE for a surgical intervention after a bariatric complication than they were to go to a BCE. For comorbidities, we found that there was a difference in patients with hypertension in which they were more likely to go to BCEs than non-BCEs. And then we did find a difference in primary payer in which Medicaid patients were more likely to go to non-BCEs than BCEs. Next table shows our outcome comparisons between patients treated at BCEs versus non-BCEs. Set up in the same way in which the second column are patients who went to BCEs, the third column is our patients who went to non-BCEs. We did find a significant difference with regards to operative approach. Patients who went to a BCE for surgical intervention after a bariatric complication were more likely to receive a laparoscopic intervention than patients who went to non-BCEs. We also found a significant difference in length of stay, in which patients who went to non-BCEs had a longer length of stay after their surgical intervention than patients who went to BCEs. We also found that patients who went to BCEs were more likely to be discharged home than patients who went to non-BCEs, and patients who went to non-BCEs were more likely to be discharged to some sort of rehab facility or further care. We did not find any significant difference in hospital mortality or hospital costs between patients who went to BCEs versus a non-BCE. The limitations of our study include the fact that this was a retrospective study with data provided to us in aggregate, which comes with its inherent complications and biases. We were also unfortunately unable to link the complications and the intervention for these complications with the primary procedure that the patient underwent. We were also unable to know whether or not these were early or late complications, given these were limitations of our data set using ICD-10 codes. And also, some patients may not be included in our analysis because of coding errors or omissions. Finally, we chose to include only patients who had surgical interventions for their bariatric complications in order to clarify our results. That being said, that means that we did not include patients who underwent an endoscopic intervention or had a non-operative intervention after their bariatric complication. However, we feel that this could be a good point for future research where we could use similar methods for complications requiring endoscopic or non-operative treatment after their bariatric complication, and whether they go to a BCE versus a non-BCE. In conclusion, surgical management for complications after bariatric surgery at BCE facilities is associated with a greater likelihood of receiving a laparoscopic procedure, a shorter hospital stay, and a higher likelihood of discharge to home. Also, African American patients and patients with Medicaid are at increased risk of receiving care for complications after bariatric surgery at a non-BCE facility. These findings should prompt a review and standardization of care and referral patterns for patients with complications after bariatric surgery, aimed at optimizing outcomes and improving value in the care of these patients. Thank you very much for your time.